All right, I just hit the record button, so I'll just welcome everyone to another GDG AI for Science event. Thanks a lot for coming on board. Very excited to have two impactful talks today from Homai and Sumaya on the call. I think they'll be tag teaming throughout the hour, but I'll hand over to Homai Dene Mayer, who's going to tell us all about. I'll let you pronounce your title, actually. So,
okay. Yes. Thank you.
All right. Thanks very much.
Thank you. Thank you, Nat. Hello, everyone. Thanks for being here for today's presentation. And I would like to thank Google Developer Group, especially Nat, for their hospitality and inviting us here. And it's a pleasure to give a talk here. So I'm Homai. I'm going to talk about one of my studies about glioblastoma brain tumor diagnosis through whole slide image analysis from multi-instance learning to prototype learning. So first of all, as I know, maybe there are some clinicians in our audiences or some computer science background people. So first, I want to briefly talk about what is glioblastoma, and then we'll go through digital pathology, deep learning models, their gaps, and then what's our proposed model. So, glioblastoma is one of the most aggressive type of brain tumor in adults, and it is notorious for its rapid growth and resistance to traditional therapies. And EGFR is one of the significant diagnostic and prognostic biomarkers of GBM. It drives development and prognosis of nearly 50% of glioblastoma in humans. Primary lab-based EGFR detections are IHC, FISH, and next-generation sequencing. However, they have some disadvantage because they need very advanced labs and experts, so they are really costly. And because of these kinds of costly labs, they are not available everywhere, so they have a lack of accessibility. On the other hand, sometimes it takes more than maybe a week to get a result, so it is time consuming. That's why after many challenges regarding these lab-based methods, digital pathology become a gold standard for cancer diagnosis. So the in whole slide images are a process of digitalization of those tissues on glass slides and converting them to digitalized and with very high resolution images. They have some advantages and over those lab-based methods. So it is really fast because just the pathologist sits and just look at those digitalized images, and it's really fast to get the results and do some diagnosis. On the other hand, because they don't need very equipped labs, so they are not costly, they are cost effective. On the other hand, because these kinds of digitalized images can provide a comprehensive overview of the whole slide images, pathologists can zoom in, zoom out, and so they can see all the details on all these digitalized images. So in terms of AI, so the most important thing, AI is not going to be the real doctor. They are going to assist doctors, physicians, clinicians. So the advantage of using AI in digital pathology is just to alleviate burdens faced by histopathologists, assist experts to provide more precise and rapid results. So in terms of deep learning models, okay, they could achieve high performance in whole slide image analysis but still they have many challenges. For example, these whole slide images have gigantic sizes. So we cannot just feed one huge whole slide image to the deep learning model. In terms of computational cost, it's really high. So there are some methods, we call them patch. We do the patching all over the segment, all over the tissue area. So on the other hand, when we get these whole slide images and we do patches, we don't have labels for every single of those patches, and we cannot ask pathologists, can you please do those annotations? No, it's not possible. It's really time consuming. We have just slide level labels. So for deep learning models, it is really challenging to find a small part of one patch which is related to tumor section. So it is the time to use weakly supervised multi-instance learning models. Weakly supervised because we have just few labels, and multi-instance learning is a concept, it's an approach that considers a whole slide image as a bag and those patches as instances. So it makes decision. If there is at least just one small patch positive, the label will be positive. Otherwise, the label of the whole slide image is negative. So what's a multi-instance learning? Briefly, it does the aggregation of patches into a slide representations. We have some very famous multi-instance learning models, and they could achieve high performance using different kinds of whole slide images. One of them is CLAM model. In terms of aggregation, they use different methods to do the aggregation and provide slide level presentations. Now, CLAM uses attention-based models. They put some scores on those patches, and then based on their scores, they aggregate patches. So then they can do classification. Or like DTFT model, it uses two steps. First, they use multiple bags, and then pseudo bags. Then they use some probabilistic methods to distill the features, and then in the second round they can aggregate these distilled features and send to their classification model. Or transformer trans-MIL, it uses transformer models, and they use these transformers to find general and spatial features, and again they can now aggregate these features and send to their classification models. They are just few samples from multi-instance learning models. So afterwards, those multi-instance learning models can use attention. They can show the histogram of their attention mechanism, which parts are important in terms of their attention. We are not sure they work always in a good way and correct way, but they can show which parts are more important in terms of their attention-based mechanism. So when we are talking about whole slide images and doing literature review, we realize all the methods, actually maybe majority of them, that use weakly supervised multi-instance learning models. But still there are gaps because always they relies on weak supervision. And when they do aggregation of those patches and provide slide level presentations, these slide level presentations are not task agnostic. They are tailored to a particular clinical task like diagnosis or prognosis. And therefore, they have some limitations in terms of expressiveness and generalization. On the other hand, when we are thinking like about unsupervised approach, So they provide task-agnostic slide representations. So no matter what's the task, diagnosis or prognosis, we can use those slide representations in any kinds of downstream task. So their learning process in unsupervised. So they based on their unsupervised learning, they can provide these representations, which are based on morphological prototypes and statistical patterns on these whole slide images. So their generalization ability is higher than multi-instance learning models. So what's our proposed solution? We decided to integrate unsupervised approach in the classification. Because now our focus is EGFR glioblastoma, EGFR biomarkers. So we only will talk about this method on this issue, but afterwards we can try this model on another kinds of diagnosis. So we aim to develop an AI-based models that automatically learns morphological prototypes from whole slide images for prediction of EGFR. And we aim to improve EGFR classification efficiency, and which can provide more accessible, cost-effective, and accurate diagnostic tool. So in this regard, our model also addresses the limitation of traditional unsupervised approach. Most traditional unsupervised approach have to start from a start point. They need a start point. They need a predefined number of clusters. So it's risky because it can there is a challenge of over or under clustering, which can reduce the performance. So we also could solve this issue related to traditional unsupervised approach. So before going deeply into our models, so I first want to talk about a little bit about our data set. So we used whole slide images stained by H&E method, EGFR amplifications, and those are public data set. If you want, you can try them. TCGA and CPTAC. TCGA has 329 whole slide images, including 217 EGFR positive and 112 EGFR negative cases. And CPTAC has 217 whole slide images, including 99 EGFR positive and 118 EGFR negative cases. So our proposed model is variational autoencoder, Dirichlet Bayesian Gaussian mixture model. Before talking about the main part of the framework, the first part, always as in all the data science, image processing methods, we have to do some pre-processing on our data. So our data is our images, and we use image processing methods to do tissue segmentation, and then after extracting this section of the tissue and extracting the background and having the tissue, we applied patching process. Then we have millions of patches. We have to extract the features from those patches. So we use a feature encoder. It is kind of foundation model. It's trained on millions of images. So it provides us 1024 dimension features. So this 1024 dimension feature means their features are really sparse. Sometimes the distances between those features can become uniform. So it cannot give us informative features. So variational autoencoder learns latent representations of these highly dimensional data. So it has encoder. It tries to learn in a iteration. It learns latent representations to find the best and suitable compressed data. 512 is the last dimension of our data. But in this regard, decoder also evaluates how encoder can provide these latent features by using its own loss functions. At the end, we'll have 512 dimension data, and then we can apply our Dirichlet-Gaussian mixture model. It takes the advantage of Dirichlet process, which is kind of models the distributions of features, and it learns the best number and optimal number of clusters from a mixture of many, or maybe I can say like infinite number of the clusters. So, and then the mixture of a Bayesian Gaussian mixture model, which doesn't rely on a predefined number of clusters. This mixture will give us the best and optimal clusters. So after gaining these optimal clusters, we only have to map them on whole slide images and just grab those prototypes. So in terms of computational task, it's really low, and it's not. We cannot even compare it with multi-instance learning models. It is really fast, and then we can just feed these prototypes to our classification model, and it can distinguish between EGFR positive and EGFR negative cases. So the performance evaluation of EGFR diagnosis model there are three different strategies: cross-validation strategy, 5-fold cross-validation. Then we use TCGA as train set and CPTAC as unseen data set. And then just to evaluate its performance over multi-instance learning models, we applied multi-instance learning models on these data sets, and then we compared with those multi-instance learning models here in this study and in other studies in the literature. So before showing the results, here I want to show the visualization of these optimal prototypes and the representative whole slide images. As you can see, image A, spatial distribution of patch level cluster assignments on the whole slide image tissue. You can see there are 7 optimal clusters for whole slide images, and C4 and C6 clusters are dominant prototypes. So the second one shows the proportional visualization of those patches assigned to each of the 7 optimal prototypes. So in terms of the results, 5-fold cross-validation results based on the clustering methods, it gives us high performance when we use our optimal prototype-based model. So you can see as when prototypes are increasing, and I mean, when we use predefined or arbitrary number of prototypes, you can see the performance drops. So it's really important to have the best cluster, the best series of prototypes here. And in some cases, for example, in 16, you can see sensitivity is 1. And it's kind of artificially high because it sacrifices those EGFR negative cases to do the correct classification. So that's why specificity here is really low. In terms of unseen data set, you can see still using optimal prototypes could improve the classification performance, and it shows the generalization ability of this method. And in terms of evaluating with multi-instance learning models, still our prototype-based unsupervised model, when uses automatic prototype-based model, it could achieve significant performance comparing with other multi-instance learning models in the literature and still in this study. Among these multi-instance learning models, CLAM could achieve higher performance among those 3 state-of-the-art methods. So, in conclusion, our method employed unsupervised learning to discover tissues' morphological patterns and summarize them into meaningful prototypes, which then guide the EGFR amplification classification model. Integrating these prototypes with the diagnostic model enhances the model's diagnostic performance and interpretability. So it could outperform the traditional predefined cluster-based models and multi-instance learning baselines. As now we are collaborating with clinicians, we believe it can assist pathologists in integrating the models into their diagnostic framework. Therefore, it can support a faster and more efficient decision-making process. Again, thank you. And any questions, recommendations?
Thank you very much. I have a couple of questions, but I think there was one question that came up in the chat, and if there's any questions from people online, then please post them in chat or feel free to unmute yourself. It's a good question. What was the expected output for the EGFR, positive or negative?
Which one?
So, which one is expected output for the EGFR, positive or negative?
So we are doing classification. The main mission is to classify or distinguish between EGFR positive and negative. It can show, okay, when we say performance is like 80%, it means 80%. It could perform 80%. Like the performance is between distinguishing positive and negative is 80%. It can find which, like maybe. How can I say? Okay, it's not just finding one positive. It finds which one is positive or negative. Maybe it's wrong or maybe it's correct.
And then there's a follow-up, and is the essence of the model naive-based? But then I think Saidal followed up with MLP was used as a slide level classifier, not a naive-based model.
Oh yeah, yes. Sorry, I think I didn't mention. Yes, the classification is MLP. Yes, yeah.
I'll ask my question if the way I wrote it down. So, what kind of score do you need for it to be clinically useful? Like, or like, is there a score threshold?
Yeah. Actually, if we even say 100%, sometimes 100% is kind of maybe overfitting.
Yeah, sure.
So I think it's better. That's why collaborating with clinicians is really important. Because after doing these kinds of classification prediction, we can ask them just one more time, go through some of these test cases to see how it could find the positive or negative cases. So I think there is no threshold. Maybe sometimes even 100% is not good enough because clinician thinks, okay, it's just kind of overfitting. But we are trying to improve it, but it's not just improving the accuracy or AUC. It should be aligned with clinicians' diagnosis. It's not just a number. Yeah.
And a kind of follow-up question from Tui. I'm keen to know about your collaboration with clinicians. How do you get access to the patient
Okay. Now we are using public data set. This study is for a public data set, but still we are collaborating with clinicians, and we can ask about the point of view about these results, and they can go through all the results. But we also have some other collaborations with other labs that they provide us private data. Of course, we all comply with all the ethics. So we have some private data as well. They provide us, they all do all the digitalization of images and gives us just images and the labels of each whole slide image.
Good stuff. All right. Thank you so much. That was really interesting. Samaya, do you want to share your screen? God. Fantastic. Let's see if this all works.
All right, can you see my slides?
Yep, yep, perfect. And we can hear you.
The screen?
Good stuff.
Yeah, thank you. Thank you so much, Nathaniel, for this session. Hello, everyone, and thanks for joining. I'm Somaya Farahani, and I'm doing a dual PhD in medical physics and health informatics. I'm really honored to share part of my work with you today. Over the course of this session, we'll explore how we developed a foundation-based deep learning model to predict key molecular markers in gliomas from MRI scans. And I want to show you not only what we did, but why it matters for neuro-oncology. But before we dive in, just a quick note, if you have any questions, please drop them in the chat. I'll come back to them at the end. All right, let's get started. So let's start with a simple question. Why focus on gliomas? Gliomas are not only the most common, but also among the most aggressive primary brain tumors. The 5-year survival rate is still under 20%, and this hasn't improved much in decades. One of the biggest challenges in treating gliomas is their genetic and molecular diversity. These tumors are very complex. They behave differently in different parts of the same tumor, and they also change rapidly over time. According to the 2021 WHO classification of CNS tumors, diagnosing gliomas requires both histopathological features and key molecular markers. And among this, the isolated dehydrogenase or IDH mutation status is one of the most important. So how do we get this diagnostic information? When it's anatomically and clinically feasible, surgeons do a maximum safe resection. That's a treatment operation to remove as much tumor as possible while preserving function. And of course, it also provides enough tissue for testing. If resection isn't safe, we use biopsy techniques. But biopsy also has some limitations. First, it's an invasive procedure. It comes with surgical risk, like bleeding and infection. This makes it hard to repeat. So we can track how the tumor changes during treatment. Second, biopsies only sample a small fraction of the tumor, and they might easily miss important genetic features. That's where MRI comes in, with different sequences that capture rich details of the tumor. This modality is non-invasive, safe to repeat, and already part of routine care before, during, and after treatment. Most importantly, MRI shows the entire tumor in a single scan, not just a small sample. All of this makes MRI a promising non-invasive alternative to biopsy. But interpreting this scan isn't straightforward. It's subjective and depends on the expert. Even for experienced radiologists, some brain conditions can look like gliomas, like a stroke or infection, which adds another layer of complexity. To address these limitations, recent studies are focused on using machine and deep learning models. In the first step, we performed 2 systematic reviews and meta-analyses of all MRI-based radiomics and deep learning studies. and found a few key issues. Most models were single task, and more than the classification model itself, performance was very sensitive to the tumor segmentation approach and the level of deep learning integration within the prediction pipeline. I mean, whether end-to-end or just for feature extraction. And many models struggle to generalize because of variations in imaging protocols and limited size of data set for development and validation. So building on those insights, we designed our model with three goals in mind: robust generalizability, multitask learning, a clinically relevant and explainable framework. So we started by building on a specialized foundation model called BrainStack Founder. Before going further, let me explain what I mean by a foundation model and by a specialized foundation model. In general, foundation models use self-supervised learning on larger scale unlabeled dataset and can then be fine-tuned for a specific task with only a small amount of labeled data. This is great for medical imaging, where annotated data is scarce and limited. These models often are often more robust to input variations. For example, a model pre-trained on a multitask center is less likely to be affected by differences in imaging protocols, scanner noise, or patient demographics. And there are two types of foundation models in medical imaging. General purpose foundation models like MedSam and MedKit, which are trained across a wide range of tasks and imaging types, and specialized ones, which are developed for specific modalities or organs. These specialized models usually give better accuracy and interpretability, and don't need as much labeled data as general ones for downstream tasks. With that in mind, model, BrainStack Founder, because it's been pre-trained using a multi-stage self-supervised process on more than 42,000 brain MRI scans. We took this strong backbone and extended it with two new modules, TAP and CMD, for simultaneous tumor segmentation and biomarker classification. The first module is TAP, tumor-aware feature encoding. It uses the SWIN-UNETR segmentation branch to guide the classification pathway. The loss function combines both segmentation loss and classification loss. So the encoder learns to focus on the tumor-centric features at every stage. Another key part of TAP is multi-scale feature extraction. The encoder generates hierarchical feature maps, each capturing a different level of detail and abstraction. You can take features from different levels, summarize and concatenate them for the biomarker classification.
Oh, Smile, we lost you. And also there's a request if you can click the hide button. You just lost your audio for a second. Click. See you, but we can't hear you.
Maybe it's better to rejoin. Yeah.
Still can't hear you. We lost your audio for like 1 second earlier in the talk. I don't know if something happened. Speakers ran out of battery.
You can hear me now?
Perfect. Yeah.
Sorry. All right.
And you just want to click the hide button down the bottom just to get that meet.google.com off the screen.
You can see the screen now.
I can see the screen, yeah.
Oh, so what is wrong right now?
Oh, there's an overlay that said meet.google.com is sharing your screen. Stop sharing and hide.
Okay.
Oh yeah, that one.
Okay, okay.
Perfect. Cool.
This
Thanks.
other
Yeah.
Sorry for that. The second module is CMD, cross-modality differential, which we designed specifically to detect the mismatch sign in T2 and filler MRI sequences. So what is this sign? In these MRI scans, the red arrow 1 points to a hyperintense area on T2 scan, T2 weighted MRIs. The red arrows 2 and 3 highlight the relatively hyperintense region surrounded by a hyperintense rim on filler scan. These patterns are classic indicators of T2 filler mismatch sign and can be some clues to IDH mutant status. So in the CMD module, we start with the tumor segmentation outputs from the SWIN-UNETR decoder. By applying softmax and summing the 3 segmented subregions, I mean the enhancing tumor, pre-tumor edema, and necrotic tumor core, we create a whole tumor probability map. We then use this for soft gating of T2 and filler volumes. This dims down everything outside the tumor and keep or even amplify signals inside the tumor region. We then use this volumes, those gated volumes are passed through the 3D convolution layers, which are weights, from which we can compute and amplify their differences. We then apply attention to stages to highlight what really matters. Channel attention that treats each learned feature maps as a channel and highlights the most informative one, and spatial attention on the channel refined features to find the exact voxel that show the mismatch pattern. We then use this for residual reweighting. I mean, we keep the original features, but boost those mismatch regions. These enhanced features are then summarized and sent to the classifier. Once we have the tumor focus features from TAP and the mismatch focus features from the CMD, we combine them and feed them into a multilayer perceptron, a lightweight multilayer perceptron for the final IDH mutation prediction. For our experiments, we worked with about 1,700 glioma patients from 6 public data sets, including TCGA, UCSF, and EGD. We use 4 routine MRI sequences, pre and post contrast T1, T2, and filler. We kept the regional protocol differences to truly test generalizability and apply the standard pre-processing pipeline. We use 5-fold cross-validation and applied online conventional data augmentation to help address class imbalance. For comparison, we benchmarked our model against several popular CNN-based models, and as well as a foundation-based vision transformer, both with 4 and 8 blocks VIT models. All right, these charts show the segmentation result on external data sets. Ivy Gap, RHUH, and University of Pennsylvania data sets. For different tumor subregions, enhancing tumor, pre-tumoral edema, and necrotic tumor core. We benchmark our models against SWIN-UNETR, which has the same backbone as ours, but is not a foundation model. It's a separate model that Its pre-trained weights on breast dataset were provided by another research team. And as you can see, our model outperformed SWIN-UNETR across all subregions and metrics, including dice score, Hans-Dorf distance, and intersection over union IOU. Okay, here you can see the generated segmented subregions by our model overlaid on the FLAR scans compared to the ground truth. And this image specifically shows one subregions enhancing tumor with the red line, and compared to the ground truth in green, with the yellow bounding boxes around them. For the IDH classification task, in external validation, our model significantly outperformed all baselines and even BIT models, foundation-based BIT models across multiple data sets. We saw the highest gains are more balanced data sets, such as EGD, while performance was a bit lower on highly imbalanced cohorts, such as IVGAP.
What are the lines and stars on this diagram? Sorry.
These are statistical differences.
Okay, all right.
Yeah. Based on the distribution of data and all of this statistical rules. In our ablation study on the EGD cohorts, for example, both TAP and CMD showed similar performance individually, and combining them improved performance across all metrics. We also assessed the effect of segmentation guidance by comparing the TAF module with the encoder output without the segmentation guidance, essentially a SWIN transformer architecture. We also tested the impact of fusing different levels of features within TAF. The results show that segmentation guidance consistently improves performance compared to the SWIN transformer alone. Interestingly, adding more feature levels didn't significantly boost TAF's performance, but for a SWIN transformer, it actually reduced performance. I think this highlights the value of segmentation guidance in our model. And to see what's happening inside this module, we looked at the occlusion sensitivity map overlaid on the FLAR scans. With features from X4, I mean the deepest stage of the encoder, both TAP and SWIN transformer focus on the tumor area and classify the case correctly. But with all four stages, the SWIN transformer misclassified the case, and its heat map shifted focus to non-tumoral areas. In contrast, TAP focused on the tumor and got it right. In conclusion, in this work, we introduced FoundBioNet, a foundation-based model for MRI-based IDH classification and tumor segmentation with two new modules, TAP for tumor-centric features and CMD for titular mismatch sign. Across highly heterogeneous data set, it significantly outperformed many CNN and BIT models, and with tumor-focused occlusion sensitivity maps, making its prediction interpretable and clinically meaningful. For more details, please check out our paper, and thank you for your attention.
Awesome. Thank you very much. There's a question straight off the bat, a tricky one, tricky for me anyway. In the chat, would foundation models be able to perform better if fine-tuned on smaller data sets, as pathology data set doesn't often have as much label, or if we should combine with multiple data sets to enhance their performance?
Okay, if I understand correctly, the question is if foundation models need multiple data sets to fine-tune on downstream tasks. Actually, there are a lot of studies that we cite them in our review articles, systematic review articles, as I mentioned before, that show evidence that foundation models actually needs less amount of labeled data for a downstream task compared to the conventional standard deep learning models, and they're more robust to variation in imaging protocols and image demographic and a lot of these with that less amount of data, labeled data for fine tuning for each specific tasks. I cite them in our review articles, but I didn't provide here.
Good stuff. Just click stop presenting on your screen. So we get, and I have a question.
Yes.
Do the models have do they have knowledge of the brain, or is it just, are they just looking at the image and just
Yes. What do you mean by knowledge?
do they understand you know, I don't know anything about brains or anything, so I'm probably using the wrong language, but do they understand like how the brain fits together, how it works, what glaucoma is, or is it just looking at the image and it's just an image segmentation task, or is it actually more interpretable than that?
Yes, I think these models, the backbone of model have been already pre-trained on healthy and unhealthy brain MRIs. And it looks at the image and only learns from the image. It doesn't do interpretation or something like this. And it was fine-tuned for tumor segmentation. But since in the first stage, I think it was pre-trained on healthy brain MRIs, and the second stage on brain tumors. I think it can distinguish between, it learns anatomical brains, and in the second stage, it learns how to distinguish between healthy and unhealthy brain tumors, brain MRIs. And I don't think it's go beyond that.
Yeah,
It's at this level, since only the model sees this data in different stages. And we fine-tuned it and extended the 2 modules for biomarker classification. Actually, we did other biomarker classification, like 1p19q co-deletion and tumor grading, glioma grading, but I didn't include it in this presentation. You can find it in other articles and or other works.
Good stuff. Are there any more questions from the cohort?
Right. So, so can you hear me?
Yep.
Yes.
Yeah. So, could you click on let's stop presenting? I think.
Yes. Sorry.
That's one that suggested. Yeah. Okay. Great. Yes. So I think just to ask a very interesting question, and you know, our theory is, I believe, and this is also related to the question, would foundation model be able to perform better if fine-tuned on smaller datasets? I guess the foundation model is, you know, this large-scale model is actually not specifically designed for any downstream tasks, but because it is so, it's a foundation model, I have seen really a huge amount of data. So the model has already, you know, learned to tell, you know, what in this specific task. So what it's not task, sorry, in this specific study, what the brain like. So it can understand largely the brain are the same, and then which part might be, you know, it should be structured in a specific way. The gray matter, the cortex, and then the white matter, and then the ventricle inside, and different, you know, structure, how the brain are wired together. And then that's what the brain foundation model has already, you know, kind of have this capability to understand, you know, the basic structure of the brain. Yes. And on top of it, if there's a brain tumor case, then definitely it's kind of look different from the normal brains. and then the model can be fine-tuned with just a few samples to pick these brains abnormalities up. And I think the powerful why brain foundation model is important, I think, is because it can be generalized to multiple downstream tasks without the need of retrain or fine-tune the model with large data sets. You can also imagine like this. So the foundation model, it's already kind of like a postgraduate student, for example. It learned the knowledges, and maybe just like have for some more advanced tasks, just need a few examples. Rather than we have a primary school student, you have to teach him a lot to perform the same level for a new task.
Yep.
In this SWIN-UNET study, I guess what we did is we adopt a foundation model, and then we incorporate some smart strategies so it can be adaptive to multiple downstream tasks, and specifically brain tumor segmentation, ADH grading, and these brain tumor related tasks, and performs really well. And I think we also compared the foundation model performance with our previous published models, which are not based on foundation models. And apparently the foundation models require less data to train, could perform better than these task-specific models.
Yes, exactly. And our results already show that across different multi-cohort, multi-center data sets and different standard deep learning models, not foundation, we can see that clearly significantly it outperforms those models.
Fantastic. Well, I'm looking forward to seeing the conclusions of both your theses. Thanks once again, Smaya and Hamai. And next week we've got Saidong and Priyanka from the AI Precision Medicine group. I think building on these topics and delivering more interesting use cases for AI in science. So thanks very much, everyone, and see you again soon.
Thank you. Thank you, everyone. Thank you, Nat.
Cheers.
Cheers.